Swapna.
Thank you, Dr. Balla, and good afternoon, Dr. Sanjay. Good afternoon, everybody. Uh, so, as Dr. Balla mentioned, I'll be talking about Phaco emulsification subluxated cataracts, and I hope my screen is visible.
Yeah.
Yeah. So basically, subluxated cataracts have certain attributes that we need to take into consideration before planning the surgery. First of all, whether it's a stable subluxation as it happens in a one-time trauma, or whether it's progressive like in pseudoexfoliation or in a disease like Marfan's. And it's depending on that you decide on whether to, just do with a CTR or go in for a sutured segment as well, or go in for a complete evacuation of the lens with an SFIO. The extent of zonulodialysis, the clock hours to which there is dialysis happening, also determines what kind of implant you want to put in. The grade of cataract, if it is slightly on the lower side, makes surgery much easier than when it's a harder cataract and you have to deal with two aspects, both the subluxation and a dense nucleus. And of course, the presence of vitreous in the pupillary area or the anterior chamber. So one of the major roadblocks is creation of the Rhexis. You can see that there would be dimpling of the capsule even during the initiation of the Rhexis. Secondly, because of the lack of traction, counter traction, then you need to make a good Rhexis. It's always hard to pull the Rhexis around. Another factor is that because there is some amount of subluxation displacing the lens from the center, we may not be able to put the pupil as the point of reference. Rather, the dislocated lens should be taken as point of reference. Like you see over here, you can see that the chamber is being intermittently stabilized by using a viscoelastic, and the Rhexis has been decentered to the left because the subluxation is there to the right. So that ultimately, when the lens is centralized, by an implant, then the Rhexis would land up to be in the center, and the optical center of the lens would correspond to the optical center of the eye. So these are the fine changes that you need to bring about in a Rhexis. You can, of course, use a micro Rhexis forceps to do all that. But above all this, you should be sure that your anterior chamber is free of vitreous for the Rhexis to happen smoothly. Now, in case there is a moderate amount of subluxation with that blob of vitreous that you can see over here surrounded by some amount of pigment, again, this is a post-traumatic cataract, and you can see that the cataract is also pretty mature with an NS3 nucleus over there. So you can see a vitrectomy being done before the placement of the hooks. So here I'm using the iris hooks, which are for vertical support of the capsule. Capsular hooks are a much better idea because they are much blunter at the point of insertion towards the capsule. Horizontal support is given by the CTR, which you can see is being implanted in the equator of the bag over here. And this provides much required stability to the lens, make sure that there's not much of movement either horizontally or vertically. Now, there are people who put capsular hooks all around, but I usually prefer to do that in the area of subluxation to lift that point up so that there is no dipping of the lens in that region. And again, the IOL is placed in such a manner that the haptic of the lens corresponds to the region of zonulodialysis, so that would provide some amount of push to that region, centering the lens. Now, this is a much more severe subluxation. You can see that it is more than 180 degrees. Again, there is a decentered Rhexis being made using a micro Rhexis forceps. And now this nucleus is not hard as the previous one. So there is a relatively good hydrodissection happening, which is very important for maneuvering of the nuclear particles during phaco emulsification. I would like to bring to your note that the vacuum and the aspiration rate all have to be slightly reduced for the to make sure that the lens does not move too much. Now, once the nucleus is evacuated, cortical aspiration is also another point which needs to be taken care of, which I'll be coming to slightly later on in the talk. Now, again, a CTR has been inserted here. But even after the insertion of the CTR, it is noted that the lens is not, the capsular bag is not centralized, because of which CTS has also been placed. So this provides an additional support to that part of the zonulodialysis, especially because the extent was more than 180 degrees. So you can see that the eyelet of the CTS over there, the small hook-like eyelet of the CTS, it would come over the capsular margin and under the iris, and that scleral tunnel over there is for the placement of the sutures. You can see the railroading of the tenoproline happening through the scleral tunnel. And once the sutures are brought out, they are buried inside the scleral tunnel. Now, this has caused the shift of the capsule to move towards the CTS placement. And you can see that the IOL is kept in the bag. You may tie the final suture of the CTS towards the end once you make sure that the IOL is in the bag. And you can also align the optic in such a way that it's exactly centered if you tie the suture at the end. Now, suppose you have an unsalvageable lens like this. You can see that it's grossly subluxated more than halfway down the pupil. Then the only option is to completely remove the lens, evacuate it along with the bag, and go in for a scleral fixated IOL. So you have your scleral tunnels made diametrically opposite, and along with the insertion into the vitreous with an MVR blade. So I use an end grasping forceps, and this is a 3-piece foldable intraocular lens that is going to play the role of a scleral fixated IOL. And once the first haptic is grasped and slowly brought out through the first tunnel, and it is put inside the small scleral aperture that is made, and then the second haptic is passed on to the end gripping forceps and again brought out to the second tunnel and inserted into the scleral port. And now the main port is sutured, and then the glue is applied to seal the scleral tunnels. I also use the glue to seal the conjunctiva on over both the scleral ports. So it's very important to make sure that the haptics are not tilted a bit or the lens remains in a horizontal plane. All the rest of the ports are hydroed. Now, if you have flax, it's very, very useful in a subluxated cataract because you can pre-program the Rhexis to a decentered portion. You can see the subluxated lens here in the OCT picture, where more of the equator is exposed on the left side compared to the right side, and therefore the Rhexis has been decentered more to the right side. So now there's a pre-programmed Rhexis. You don't have to tug, you don't have to pull. Also, there's some undulations on the capsule, if you can see in the OCT picture. So you may need to adjust your delta a bit upwards and a bit downwards more than what is usually programmed, so that the entire capsule is covered. So you have a pre-programmed Rhexis, you have pre-nucleotomy done. So the maneuvers decrease a lot and the chances of error are also drastically reduced. Now, this is the patient on the table. You can see how the free-floating Rhexis comes out, and all you need to do is a good hydro so that you can pass your CTR in. So this is no a way out of a CTR or a segment. It's only that some parts of the surgery are made much easy, but the application of a CTR or a CTS is inevitable in most cases of subluxations. There are few subluxations where you can just do a phaco under low parameters and get away with it, and the lens remains as such without tragedy. So now coming back to the part where I said that after phaco emulsification, now here the maneuvers are much less because there are nucleotomies made. So you just need to be very sure that you are separating the nucleus completely, because sometimes the nucleotomy doesn't go all the way down in flax, and you need to do a manual separation of the posterior plate. And the emulsification carries on. In cortical aspiration, some of the important points that need to be noted, especially in the placement after the placement of a CTR, is that the cortex may not just come out very easily. You may need to hydro the cortex a bit and then pull it out radially for it to come out easily without disturbing the CTR. So now there is the placement of the lens in the bag. So some of the aspects, some of the take-home points that I would like to drive in is that the parameters except energy need to be lowered a bit. So if you usually use a 32 AFR, please bring it down to 24 or 28. Now, if you're using a vacuum of 600, you can get down to 250 or 300. So this is to maintain the stability of the lens. There should be both horizontal and vertical capsular support during phacoemulsification. And depending on whether the subluxation is gross or it's progressive, you can use the placement of permanent segments in or permanent rings with sutures in the capsular bag. And of course, skill regarding glued SFIOL is very useful, especially if you go wrong in any of these steps and you need to remove the lens in toto. Thank you very much.
Thank you, Dr.